Picture this. You're standing right at the bedside of a hemodynamically unstable patient. The monitors are blaring, the blood pressures are soft, and, well, you need answers fast. But before we even start figuring out the why behind their deterioration, there's a surprisingly simple physiological question we really should be asking. How far does a single column of blood actually travel in exactly one heartbeat?
Welcome to This Explainer. Today, we're totally demystifying LVOT VTI. Now, if you're familiar with that deep navy and gold aesthetic, you already know this is a core plexus explainer. That means our absolute focus here is on visually mastering cardiac hemodynamics. So let's figure out how to take this kind of intimidating string of letters and transform it into literally one of the most powerful non-invasive tools we can possibly bring to the bedside.
Okay, here's our roadmap for today. First, understanding LVOT VTI, then the measurement process, hemodynamics and normal values, calculating stroke volume, and finally, clinical context and pitfalls.
Let's dive right into part 1, understanding LVOT VTI, or the distance of flow.
So, LVOT VTI, it stands for Left Ventricular Outflow Tract Velocity Time Integral. I know, it's a huge mouthful, but honestly, despite the highly technical name, the core concept is just incredibly elegant. It is simply the measurement of the physical distance blood travels through the left ventricular outflow tract during one single heartbeat. We get this metric using pulsed wave Doppler on our ultrasound machines, and it's an absolutely essential parameter for assessing both stroke volume and cardiac output. The real trick here? Don't think of it as a speed. Think of it as a physical length of fluid pushed out by the heart.
When you look at a Doppler wave captured during systole, that highlighted section, the VTI fill, isn't just some abstract mathematical shape. No, it literally represents the physical distance the blood has traveled. By integrating velocity over time, the ultrasound machine calculates distance. It's just this beautiful translation of physiological flow into a visual metric that we can actually see and measure.
All right, moving on to section 2, the measurement process, step by step.
Getting this measurement is pretty straightforward, requiring just 3 precise clinical steps at the bedside. Step 1, you got to get a really crisp apical 5-chamber, or A5C view, though an apical long-axis 3-chamber view works perfectly too. Step 2, place your pulsed wave, or PW, Doppler sample volume right in the LVOT, just a few millimeters below that aortic valve. And step 3, once you have a nice clean waveform, you just trace that Doppler envelope to obtain your VTI. It's actually pretty fascinating when you see it in action. You've got color Doppler showing the blood moving towards the aortic valve alongside the precise placement of that sample cursor, and tracing that bright golden envelope on the resulting waveform completely translates the velocity curve into a distance. The main metaphor to keep in your mind here is that this traced area under the curve is the total distance a column of blood travels during systole. You trace the flow, you get the distance. Simple as that.
Next up, section 3, hemodynamics and normal values. How do we actually interpret the numbers?
So the absolutely crucial point here is knowing our baselines, right? A normal LVOT VTI is going to be between 18 and 22 centimeters. Now, if your patient's measurement is falling below 18 centimeters, you're looking at a reduced stroke volume. The heart just isn't pushing that column of blood far enough. Conversely, if it's greater than 22 centimeters, you've got an increased stroke volume, which could be pointing to a hyperdynamic state. But generally, 18 to 22 centimeters, that's your golden target for healthy forward flow.
Let's look at section 4, calculating stroke volume, or the math behind the flow.
Okay, let's dive into this and see how it all builds into an actual hemodynamic profile. Remember the cylinder metaphor we discussed earlier? Stroke volume is basically just the volume of a cylinder of blood. To find it, you multiply the base area, which is the LVOT area, by the height of the cylinder, which is our LVOT VTI. So let's say you measure an LVOT diameter of 2.0 centimeters. The math gives you an area of 3.14 square centimeters. You multiply that by our normal VTI of 20 centimeters, and boom, you get a stroke volume of 63 milliliters. Take that 63 milliliters, multiply it by a heart rate of 75 beats per minute, and you have just calculated a cardiac output of 4.7 liters per minute. And the best part, you did it all completely non-invasively, right at the bedside.
Actually, scratch that. Before we get too lost in all those formulas, I really want to anchor you with this direct quote from the core plexus source. LVOT VTI reflects forward stroke volume. Honestly, that is the fundamental takeaway here. The math is great, sure, but even on its own as a solitary number, the VTI is a direct, proportional window into exactly how much forward flow that left ventricle is successfully generating.
Finally, Section 5, Clinical Context and Pitfalls. Let's bring it back to the bedside.
There are just massive advantages to this technique. Because it's completely non-invasive and with just a little practice, super easy to perform, it is absolutely perfect for serial monitoring. Think about it. You can check a patient's VTI, administer some fluids, or maybe start a pressor, and then just check it again to see the real-time physiological response. And beyond just stroke volume and cardiac output calculations, it's routinely used for evaluating heart failure, assessing the severity of aortic stenosis, and guiding ongoing hemodynamic monitoring in the ICU. It's a real game changer.
But, we absolutely have to be careful here. There are a few limitations. First, you have to be meticulous because an incorrect LVOT diameter measurement will cause a huge error. Remember that math from earlier? We square the radius to get the area, so literally any millimeter of mistake in your diameter measurement is amplified exponentially. Secondly, poor Doppler alignment is a massive trap. If your ultrasound beam isn't parallel to the flow of blood, you are going to severely underestimate the VTI. And finally, arrhythmias. They can wildly affect your measurements from beat to beat, which means you're going to need to average several waveforms to get an accurate clinical picture.
So, armed with this visual understanding of stroke volume and the hemodynamics behind the Doppler wave, how will you incorporate LVOT VTI into your next bedside assessment? The next time you're faced with a tricky hemodynamic picture, I challenge you to pick up that probe, find the LVOT, trace the wave, and let the distance guide your clinical decisions. Keep learning, keep scanning, and we'll see you in the next explainer.